Okay, thanks for joining us, everybody. We're glad to have you today. We are going to be discussing the medically minded practice, how you can do that in your own practice, and maybe how that's changed a little bit in these crazy times. So before we dive in, I want to introduce myself. I'm Dr. Patricia Fulmer. I'm joined today by Dr. Adam Ramsey, and we're really excited to talk to you guys today. So just a little background on myself. I'm a 2012 graduate of UAB, School of Optometry. After that, I went out to Texas and did a residency in primary care and ocular disease at a VA hospital there. So lots of patient encounters, lots and lots of disease there. And then I was fortunate enough to come back to Huntsville, Alabama, which is where I was born. I grew up a little bit a ways from here, but I'm happy to get back and took over a position of a center director role in a tertiary care facility, so all medical. So no primary care at all. We did no glasses, no contacts in that setting. Everything was referral based. So pretty much anything that our referral network needed care for, I handled along with our surgeons and managed the staff as well. So that was quite a fun thing to jump into right out of residency. After that, decided I wanted to get back into private practice in primary care. So I joined a friend's practice as an associate in 2017 and have been there since then, but am recently starting a new endeavor of opening my own practice. So looking to do that in the fall, should be open somewhere around November. Really excited for that. As you can see, we've got some construction going. So that's one of our most recent pictures. We finally got walls up, which is always the exciting part. I've also been really blessed to work with New Grad Optometry and Covalent Careers and do some of their show planning for Vision Expo so that we can get great content out to you guys for any topic you could possibly dream of. So through that, I actually was fortunate enough to meet Adam before this and work with him a little bit. So I'm really glad and excited to join him today. I also served for the Alabama Optometric Association as a board role and also as president for the North Alabama zone or part of the association. So I'm going to throw it to Adam, let him tell you a little bit about himself.
Well, thank you, Patricia. Appreciate that. Nice introduction there. So my name is Dr. Adam Ramsey. I also graduated in 2012. And this is the great thing that you get to see two people that graduated at the same time, had different career paths, but are ending up at the same place talking to each other today. So I graduated from Southern College of Optometry in Memphis, Tennessee in 2012. Private practice, entrepreneurship, being self-employed has always been my thing. So right after graduation, I pretty much opened Iconic Eye Care. I was a doctor next to an optician, and I did the exams, sold the contacts, did all the dry eye, anything I could get my hands on or do in that space. That was my focus, and that's kind of what made me so medically minded now, because my first 3 or 4 years of practice, I wasn't making any profit off the optical. So I had to hone in on my skills just on medical optometry because I wasn't making any money in the optical. So I could not relax on trying to sell glasses. I wasn't making any money there. So I did 3 years of having that. And then patients were asking me, hey, doc, we want to do the whole thing with you. Can you open up your own place? And, after enough people tell it to you, you said, okay. And in February 2016, I opened up Social Light Vision in Palm Beach Gardens. And that has been a wonderful endeavor. You can see this is the optical, and I have a screen in there where we do presentations. Before, when we would be able to bring people in, we would do lunch and learns. I did a dining in the dark presentation in which the kids were blindfolded and they got an appreciation for sight. I've done a dry eye and allergies presentation where we brought in patients and wine and cheese things, all that kind of stuff in the optical. Try to have some fun and educate at the same time. In 2017, the year after, I opened up not 1, not 2, but 3 Indian reservation locations as satellite locations. So I have the contract for the state of Florida, and I go to Indian reservations and see patients on there. And it's a full clinic with visual field, fundus camera, slit lamp, et cetera, et cetera. And we do the glasses on site as well. So as you can see, medical optometry and expansion has been my thing from the very beginning. I also co-founded Black Eye Care Perspective, where we're giving the eye care industry an understanding of some things that Black patients need and the perspective of Black optometrists that are out there. So after writing all that stuff and doing all that stuff, I decided to write a book, and it's called Play Chess, Not Checkers, the practical guide to open warm start your dream optometric practice. It's teaching doctors how to actually open their own practice. So that ones that want to actually go out there and do it for yourself, it's there. and I am the chairman of the board, coming off of the board now for the Palm Beach County Optometric Association. I did my 7-year term, and finally coming off there was a wonderful experience, being able to give back to our profession that I love so much, and I want to give back. So just a little bit about me. I love it, and I can't wait to do this presentation and be able to educate and guide everybody that wants to do a little bit more medical optometry and is just trying to figure out, can I do it in my space? Can I do it in this setting? Is it possible? No, I can't. I have worked in every commercial setting imaginable. I have worked with ophthalmologists in an office. I have owned my own practice. It is possible, and we're going to go over some ways in which it can be done for you as well.
Sounds like I might need to go buy your book, Adam.
Come on now, let's do it.
So, obviously both of us have a passion for sure for medical optometry. But, I think that term, and real quick before I go there, our disclosures are simply Zeiss and Allergan for myself, Zeiss, Bausch & Lomb, Alcon, Wagner Color Vision, and Transitions for Adam. But as I was saying, the medical model sometimes I think gets to be an intimidating title for some optometrists because they think that they can't necessarily do that. And that's a perception that I think you and I both have worked really hard to kind of dispel, because it is absolutely doable. So before I talk a little bit about what it is, I'd kind of like to talk a little bit about what it's not. The medical model is not time consuming. I hear that from a lot of people when I talk to them at shows. I can't fit it in my schedule. I can't work it in amongst my, routine vision exams. It's going to take me too long in the room. I need to flip my room. That's not the case at all, because you learn to manage your schedule in a different way. So just because the patient is there for a vision exam doesn't mean that you have to spend, an extra half hour running 18 different tests because you found something. It just means you found something and you need to educate and plan accordingly so that you can give that patient, the amount of care that they need in whatever space that is. I've also heard a lot of times that it's only for practices that can afford every single diagnostic equipment that's out there, and it can't be done in commercial, and it can't be done in a single practice, and just all kinds of things like that. And while it's really fun to have all of that diagnostic equipment, it's not mandatory. You can absolutely start from things as simple as just your slit lamp and your brain and what you were taught in school. And I think that's the really awesome part about optometry, because we are given so much to work with when we come out of school in so many different ways, and we can apply that to our patients no matter what kind of area of optometry we choose to practice in. So what it is simply, it's a practice builder. It's a way for you to give extensive, complete care to your patient, because we're not just refractionists anymore. We don't just say which is better, one or two. We look at the entire patient and the entire eye and their entire systemic body health. And that means that we want to give them full care. And that sometimes does mean working with other people, but a lot of times it means that you can handle that in your office. And by doing that, you build your practice. You can do that in any setting, any doctor. And it's really applicable to any patient. So it doesn't have to just be, okay, I only see kids, so I can't really do medical, or I only see geriatrics, so it's going to take up too much time. It can definitely be done in literally any setting, anywhere. Would you agree with that, Adam?
I definitely would. And to follow what you're saying, I think of the medical model mainly as a few more follow-ups. That's all it really is. And if you have a lot of the follow-ups, the visits actually don't have to be that long. They actually are quite short visits. They're just a whole bunch of short visits. And those that want to implement it, it's literally about sliding them in. Yes, you have the patient in there, but they're not going to be in there as long, because every time I see them, I'm not doing every single test. This time I'm seeing you can't do the OCT and the photo, easily on the same day. So one day is the OCT, one day is the photo. So it's just a whole bunch more follow-ups. And when people talk about needing all the equipment, all the toys are good. And we'll show you, I have a lot of the toys in my office, right? But I didn't have them to start. And I was still a great doctor without that. And I think starting off without it at first and making me use my brain and not being so reliant on looking at that printout that says green and yellow, red, and having to actually look and ask the right questions is a great way to start. And as you build up that medical model in your office, then you can justify adding on the equipment. But first you start with a fluorescein strip, a cotton tip applicator, the red cap, assess the optic nerve health. There are things you can do with no money to get started. And after you've assessed enough of those things and you've done enough, you can then follow back up and say, okay, now I want to go buy a bigger toy, and I've proven that my practice can handle that. So it is definitely a practice builder. People love it, but the medical model is the practice builder, not so much the equipment. The equipment is great, but people are coming to you for your expertise. We feel like we need the equipment, and I love the equipment, and I have the equipment. But first, you start off with you being a doctor and building up that medical base. And then as you build it up, then you bring on the equipment, and it just expands what you can do without having to refer out as much.
Yeah, I completely agree. And those follow-ups, which leads into another question I have for you. You know, when we hear people say to us, you know, it takes time away from my routine visits. How do you take a patient who comes into your office and they're there for just their regular glasses and contact exam, and you find something? How do you transition that patient into the medical model and these follow-ups and get them to understand why it's important for them to come back?
I am not in the lane of, okay, I want to make people that want to use their vision insurance plan have to use their medical for the annuals. I am in the lane of whatever the patient is asking to use for that first visit, that's what I'm doing. Now, I just don't have to deliver all that care and answer all those questions on that same exam. There are some things that need to be followed up on. When you're asking me to write a letter to your PCP for your diabetes, that isn't covered under your vision plan. So that requires a follow-up visit. And at that follow-up visit, then I will do the additional test and I will do the things you need for that medical portion of the exam. But if you would like to buy these glasses, your vision plan does provide you the ability to do that. And all we're doing now is the patient is happy, and I don't have to have an argument with the patient. I think the second we start having that argument and butting heads with the patient about what they're asking, I think we're going about it the wrong way. And as a practice builder, it's really not necessary. I think it really just needs to be a conversation with the patient. The patient wants to do glasses, they want to do contacts. Sure, we're here for that. Then when you start asking me about dry eye allergies, your diabetes, everything else under the sun, I'm sorry, we're going to actually do a follow-up for that because I want to be able to focus and hone in exactly on that portion of the exam. So I'm going to bring you back in a week, in a month, in 6 months, and we do that portion of the exam, and then patients get used to the schedule of, I use my vision and plan in January, and I come in June, and I'm here for my medical exam, in which we go dive deeper into my diabetic or my glaucoma or whatever else that is needed for them at that visit. I don't think there needs to be an argument. I don't think it needs to be a headbutt with the patients. I think it just has to do with communication and talking, and I think people are okay with that. And you can see some of the toys, every square inch of my office, there is stuff, and there's more toys in the hallway, and there's more stuff there. But I just added one per every year. You know, somebody sells me on something. These guys are pretty good at selling you. And then, you know what? I haven't regretted any of the decisions. I love it, and it's hard to practice without it.
Yeah, I completely agree. I mean, you know, for us, and I think that's another really awesome point to the medical models, it can be done in your own way. So whatever you're comfortable with running this is how you should do it. So, you know, if you have a patient in your chair and there's something simple that you want to go ahead and have that conversation with, and you know, if you need a test that day because it's something extremely important or pressing, you can do that. Or as Adam went into, you can absolutely set that as a separate medical visit. A lot of times patients don't really understand the difference, you know, as we know, between their vision and their medical insurance and the divisions there. And when you educate them, they tend to be much more on board with all of these follow-ups for whatever it is, anything from, you know, dry eye and allergies to glaucoma to neurological issues, you know. And when we do those tests, there's occasions that we need to run a medical test on a day that they're there for their routine vision exam. And when we do that, it is possible to bill your medical insurance for that test as long as you have things documented in the correct way. So it's such a flexible model that's really the key, in my opinion, on why it works for every patient and why it works for every doctor, because you can really make it fit whatever is going to be best for you and your patient, keeping in mind that the follow-ups are really the key. That's exactly where that model comes in. So practice revenue, everybody likes to talk about that, right? I don't think any of us went into business to not make at least a little bit of money somewhere down the line. You know, we talked about the toys, and of course they come up with the more and more that you build your practice and you're able to afford things. I think Adam's approach is great. One new thing a year, because usually there's something great that's come out in the year, and there's a lot of good deals out there sometimes. But you know, when we look at the bottom line and we really look at why we're doing this, first of all, it's going to benefit your patient the most because you're not trying to cram everything into one exam. You're not trying to give them the rundown on their glasses, their contacts, their glaucoma, their AMD, their cataracts, everything all in one where they don't remember any of it, because plenty of studies have been done to show how long patients are really with us when we talk, and it's not very long. So anytime that you feel like there's something that's maybe going to be a little more complex, that's a good time to think about those follow-ups. With glaucoma, for example, space those testing out. You can do more than one visual field in a year. I hear that rumor a lot, or even in 6 months, if it's medically justified. So if you have a patient that comes in and maybe it looks like progression and you need to confirm that because that's going to drive your decision making and how you're going to treat that patient, you can repeat that test in a few months. It's just all about your documentation, all about your patient education. As you mentioned, of course, OCTs and photos are definitely not allowed on the same day. Most of your diagnostic equipment are going to have two types of tests. You're going to have your medical diagnostic test and typically a baseline type test. And you can run those and do those separately as a patient out of pocket if you need to. But you have to interpret them differently. They're not quite as in depth as your main, say, OCT for the day. But photos and OCT are definitely not billable on the same day, so you want to separate those and just space that testing out throughout the year. But for me and my patients, I've found that the more that you educate them, the more they're going to work on your team, because they're able to really engage and be a part of their health and not just, getting things thrown at them or here's your paper, here's your drop, I'll see you next time. How do you go about educating your patients and getting them on your team, Adam?
I think patients have to know that you care before they care what you know. Mm-hmm. And I think starting off with, I care about you, Mrs. Smith, and I'm looking at your eyes and I'm seeing some retinopathy that I'm not too happy about. And we talked about it last time, and I need to connect with your primary care doctor or your endocrinologist and get your A1C, because I've asked you a few times and you're not giving me the proper A1C, or you're not giving me the information, or the A1C number that you're giving me does not equate to what I'm seeing. A 6.5 and this kind of bleeding does not go together. What we're going to do is we're going to bring you back in a month, because you told me you're going to go get your blood work next week. So I'm going to see you back in a month. That way you have the proper blood work, and I'd be able to connect with what your eye and your body looks like with certain A1C and certain blood sugars. And then the patient understands that, oh, he cares about me. And then they're like, okay, I'll come back because that doctor really gets it. And I think that's where you can separate out what you're doing and how you deliver that care. Now, the one thing about the medical model is that after you pay off the equipment, or the equipment has a set cost for that month, after that, that is all extra. The thing that I struggle with, even in my own private practice, is that optical revenue has a cost of goods. Those lenses cost money. Those frames cost money. So even when I try to decide on increasing practice revenue, I really care about the profit. And it's really hard sometimes when those other products actually come with a cost on the back end. The good thing about the medical model is that there's no cost of goods. You have a set cost and you can do it over and over and over. All these toys are wonderful. They give you so much information. They're repeatable. And that's the key thing that I really love about any machine, is making sure that I can trust the information to be the same to the same patient all the time. There are a lot of instances in which you can do photos and OCTs if they're for different reasons on the same day. And at the end of the day, it's up to us to make sure that our practices are profitable. It's not up to the patient. It's not up to the insurance company, because you got to remember, they are running their business, and their business is not to pay us. Okay. Their business is to pay us the least amount. Okay. Our business is in making sure that we tell the insurance company appropriately what we did and talk to the patient in which this is needed and this is understood. And I think with the communication with the patient, they'll understand. We're coming in for this. We're going to handle this on this day, and we're going to do this other thing on a different day. And then we just separate out the tests in which the patient is not doing the same test every time. So they understand I got brought back because this needs to be done on a separate day. My glaucoma patients, I like seeing them in the morning, so the eye pressure is higher. So when they're coming in at 2 in the afternoon, and I tell you, I need to really assess your eye pressure first thing in the morning to give me a more consistent basis for how your eye pressure is every single time. And right now it's 3 o'clock in the afternoon, and that's not a good time for me to assess your eye pressure. So now all of a sudden the patient is not mad at me for coming back. They understand the medical necessity for coming back for a separate visit. And then whatever the cost is to come back at that visit, that's not our fault. That is insurance company or you not having insurance. and paying out of pocket. But I think the communication is what people miss out on, and where you have issues. And I think once you communicate with the patient, you can enjoy all this increased practice revenue from doing the different tests and bringing in the resources that does come with doing the testing. But we're doing the testing so that we get the information for the patient, so that we can be a better doctor, that we can thoroughly understand what's going on. And some of these wonderful machines that we're looking at here on the screen, there are some times, and I can give a story, there are some times when I've seen patients, and all of a sudden when I use my Claris, and I saw that patient 6 months ago, and I'm looking at it and I'm like, that little nevus, I didn't see it. I thought I saw it. I look back at my notes and it's not there, but now I see that they're clear as day, and it really does help. I really do love having that documentation. And then even when I go to compare something, it's not in my notes, I go back and look, and I have the picture to look at that. Or the OCT, these epiretinal membranes are really tricky. Or these PEDs are really tricky and harder to see. So having wonderful, clear, consistent screens and consistent billable tests, and it really does help increase that practice revenue and allow us to have a more thorough and complete exam. One thing that really drives practice revenue is referrals. And when you show this patient, I have a big screen in my exam room, and I'm showing the patient this stuff on the big screen. I'm like, have you ever seen the back of your eye before? And they're like, no, nobody's ever seen it, but nobody's ever shown it. I'll ask them where they went. And sometimes I know the practice they went to has some of these tests, but sometimes the doctors are not showing the patient. They look at it and view it before they come in the room. And then they're like, oh, it looks good. And they just go ahead and do their, refraction and do the slit lamp, and then they're out. But the patient wants to see it. That's the biggest practice builder. So whatever equipment you have, let the patient see it. And they were in awe. When I was in that little small place in that optical, and I didn't have all the bells and whistles. The bells and whistles I did have, I showed the patient, and I talked with the patient. And even when I had nothing, they were like, this is the best exam ever. And in the back of my mind, I was like, I don't have an OCT. I don't have this. I don't have that. And, and then today they still say, this is the best exam ever. But it was still the best exam before. And as I just kept going, it still was the best to that patient. And I think it was mainly due to the communication. And then the more toys you have, use it. And the more you have, just explain and educate the patient. And that communication is really critical to increasing that practice revenue.
Absolutely. I don't think there's almost any patient in our practice that we take photos of that I don't show them that. It's so impactful to those patients to really see that and become a part of their care. So often we go to any doctor and we're just in and out, and we kind of don't really know exactly what just happened, and we heard, but we didn't necessarily understand. And when you take the time to really walk through that testing, and even sometimes with my glaucoma patients especially, I'll pull up their OCTs and things like that, and that's where I may simplify it down a little bit to the greens and the yellows and the reds, but it gives them a way to really dig deep and understand what's going on with their eyes and with their vision, and therefore with their body, so that they can apply that later to, I should probably use this drop tonight because I want to see my grandchild play soccer, or, I understand that my diabetes is threatening my vision because my doctor showed me that. I saw the bleeding back there. I saw the, blood vessel growth, or the leakage, or whatever it may be. The picture there in the center of the screen is actually one of my most favorite patients. She came into us basically light perception from cataracts that had just gone way too long. She really hadn't had a good thorough exam in quite a while. She was lost to follow up for a number of years to whomever she'd seen before. And when she came in that day, she came in with her son, and we just sat and talked, and we, couldn't really see a whole lot in the back because just as she couldn't see in, I couldn't really see out, but I knew she needed cataract surgery, and I knew her diabetes was really out of control. So let's do what we can do. So we got her cataracts fixed, and she went from light perception to about 20/40. So she was already over the moon from that. And at that point, we got photos, and we showed her because she said, I had laser at some point, but I don't know what it was on. I really don't know what it was for. And once I could finally see back there, as you see in the photo, most of her retina had been lasered, and she was then able to see it and understand why her vision can't be 20/20 today. And it's hard to tell in that picture because it's small, but she had a lot of bleeds within her central zone there. And so the usable retina she did have was threatened, and it let her really get on board with why she needed to tighten down on her care, because she wants to see. She's not that old. She needs to be out there and living her life. And, to see those impacts that you make just through taking the time to educate is really incredible. And we use those photos too as baseline all the time. And we also, I agree with you, Adam. I can't tell you how many nevi we've picked up and been like, oh, we didn't see that. I know I dilated. Sometimes they wash out, or it's in a weird place that a patient's not looking, and you go, oh, I thought I was really good at a DFE, but okay. So Claris has definitely changed our practice for that. But a lot of times when patients come in for their, say, routine visit, maybe they have a history of AMD. We may do a retinal baseline screener that is out-of-pocket pay, and it's, as I said before, it's interpreted different. It's a much more basic interpretation than a medical scan would be, but it does two things. One, it allows me to educate the patient, which I know we've said that 100 times, but it is absolutely the root of everything. But it also allows me to say, okay, you have something that's starting to develop. I can't see it on the surface yet because we're not there, but that's a good thing. That means that we can get ahead of it. But it also means we need to start running these scans, periodically, getting you on an actual schedule for follow-up. And then it becomes a medical model patient where they're coming back for those follow-ups. They're, on their AREDs or occupied, they're doing whatever it is that we are recommending them to do, all because we took the time. And from a practice revenue standpoint, that's an extra test. It's an extra private pay, no insurance involved income that you're getting for your practice. So, all of these tools can typically be used, maybe except a visual field. That'd be kind of a boring baseline test to take, but you can do most of these things in a separate way to help increase your practice revenue in addition to doing it for your medical model.
Well, you gave some good stories. I want to give a quick story. So what I would really recommend is that I have all these little fancy machines here, but showing the patient is so important. I can't tell you how much drops and foams and heating and cooling pads I have sold just by showing a patient their blepharitis, because they can't see it. You can't give them a mirror and they hold it up. They can't see it up close a lot of times. So it's not going to work. But at our office, we take an anterior seg picture, even though I'm looking at it on a slit lamp. The picture is not for me. It's for the patient. And I zone in and I say, did you wash your eyes today? And she's like, yeah, I washed my eyes. And I say, okay, what's this then? She said, I don't know, that's on my eyes? And I'm like, yeah. And I was like, you need this to clean it with. Boom, $40. When I look at the eye in the back with the OCT, I can't tell you, until I got an OCT, I can tell you how many epiretinal membranes I've seen now that I go back and I look, and I have my old camera that I had before, and I have the photos, and I pull it up, and I've looked again, and I'm like, I don't see the epiretinal membrane. I am looking with my own eye fresh, and I'm like, I do not see it. And I go here and you see the epiretinal membrane. I'm like, that's why they were 20/25 or 20/20 -2, or that patient with contacts that you can't figure out why they're always complaining, and you look right there. And sometimes it's epiretinal membrane, or sometimes it's PED detachment, or sometimes it's something really small that I have seen on the OCT. And then I go back to the photo and say, could I have seen that without that? And there's so many chances where I'm like, listen, I'm good, but I'm not that good. I just can't see that. It's not there. And I've sent it, to retina people and be like, am I missing something? And they're like, no, that's what you needed technology for, So once I get one toy, I get the next one. Next thing I like to do is I let the patient look at the scans, look at the OCT. And I have them answer the question, what do you see? And they're like, well, that one's a little lower on that side. Or that one was green. Now this one's, yellow. Or that one's a little wavy. I see it looks a little different. And I'm like, yes. So remember I told you last time how you needed to do X, Y, and Z, and you came in and said, well, I don't see a difference, so I stopped doing it. This is the result of stop doing it. Now when the patient is engaged on their own care, they can see it for themselves because you're showing them the before and you're showing them the after. Now all of a sudden, I'm not forcing them to do what they need to do. They see the negative effects of not doing it. So I would say anybody who's watching this right now, wherever you are and whatever equipment you have, you can use it. And as you use it and you get more comfortable with it, you go and buy the next toy. And then after you do that and you fully flush out the ability to use that equipment and use it to its full capability. That's the one thing. Sometimes we have toys. A visual field may seem simple, but that 10-2, a Tosis visual field, some of those things bring out a lot. I used to do a screening visual field on patients, and it took like a minute to actually do. And before I had all the other fancy toys. And patients would love that, and they would do it. And I caught some tumors, and I caught some things on that I may not have caught otherwise. So whatever you have, use it to the fullest, its fullest ability. And then when you get the next toy, use that one to the fullest ability, but show and educate the patient and bring the patient into the discussion of their own care. And then all of a sudden, you'll have a patient, which happened to me. She came to me one year. The next year, we tried to follow up with her. She didn't show up. I said, okay, move on, see the next patient. About 3 or 4 months later, she comes into the office and I'm in the optical. And she says, Dr. Ramsey, I got to talk to you. And I'm like, what? And I'm trying to remember the patient. I'm trying to figure this out. And she's like, I have to apologize to you. And I'm like, what are you apologizing for? She said, I cheated on you, Dr. Ramsey. I said, what do you mean you cheated on me? I'm like, we don't go together, nothing.
That's my favorite phrase.
Exactly. She said, I cheated on you. I said,
You
what?
did what?
She said, I went to go see somebody else. And I don't know what they did, but that was not an eye exam. She said, but I said, well, Mrs. Smith, you used your insurance already, so you'd have to wait a year. She's like, I can't wait a year. I need you to do what you did last time. I need you to do that again, because I don't feel like my eyes were actually checked. Because what they did was not what you did. And when you actually separate out where the patient understands what has been done on them, because a lot of times you can go through an exam and you do all the toys and you do everything, but the patient does not know what happened. They just know you said that I can see good. Here goes your prescription, go in the optical and buy product. But if they understand what they did and you explain the different tests and what the results and the reason why I did these tests, if they go and cheat on you and go somewhere else, and that other place did not do the length and breadth that you did, now all of a sudden in the back of their mind, well, am I really good? He said I was good, but he didn't do what Dr. Ramsey did. And he didn't talk about cataracts, even though Dr. Ramsey said I had them. He didn't talk about my diabetes or my glaucoma. I'm a suspect because I have a family history in the back of my eyes. He said the cups are really big. I think he doesn't know what that means, but he just says, that stuff. And then all of a sudden, now you are having a practice village. Now they won't go anywhere else because you're doing something that the person down the street is not doing or is not living up to that standard. So I challenge everybody, go for it, do it.
Yeah, I completely agree with everything that you said. And, we've talked a lot about technology in general and thrown out a bunch of different things that we can utilize. Start with just you and look and think about what it is that you want to grow your practice into. Do you want to be more into the glaucoma or macular degeneration disease space? Do you want to be more specialty contact lens, which also incorporates some medical, because you're absolutely, treating things like keratoconus or what have you? Where do you want to go and how are you going to get there? So my approach and what I tell a lot of people to do is start basic. So fluorescein strips, we mentioned those earlier. I still to this day probably use that just as much as I use any other piece of diagnostic equipment, because every one of my dry eye patients is getting stained on a regular basis. I see those patients back, especially in the beginning, anywhere from a couple of weeks to a month, and with monthly to quarterly follow-ups for quite a while, because it takes a little bit of time to get them completely controlled. And in a way, in Alabama, we have a lot of fluctuations in our seasons, and we've got a ton of pollen that's pretty much 365. And so they're dealing with all kinds of things throughout the year. And that means that we've got to stay on top of that. What am I seeing a lot of that I would like to be able to treat more thoroughly? Maybe I've got a lot of glaucoma patients and I've diagnosed it, but I'm not able to do the full gamut of testing because I don't have that in my office. Then I start to track, how many patients would I have run an OCT on in this quarter had I had one? Okay, track those numbers. Let's look at the metrics. Will it make sense? And if it does, go for it. Absolutely. If you're going to utilize a visual field more, make that step next. Whatever it is that makes sense for your practice, add that on. And then the next year or the next time that you're able to afford to add something, do the exact same process and see what's going to make sense for you. We're in a really exciting time when it comes to technology, in my opinion, because we've got so many new things that we couldn't do even when you and I got out of school, Adam. I mean, OCTA wasn't even a dream at that point. Anytime somebody needed an angiography, they were booted to retina that day, But now we have things like the Sierra 6000 that you can run that on absolutely in your office right there that day and teach these patients. This pictures of, proliferative diabetic retinopathy. You could absolutely tell somebody exactly what's going on in the tiny, tiny vessels in their eye that they can't even wrap their head around how small they are. just by showing them this picture without having to make a referral.
What I did before I got every single piece of equipment is I didn't do it on a quarterly or 3 month. I actually did it on a weekly and monthly because I looked at the payment was this much per month. So how many of these do I have to do to equal that payment, right? And I looked at it per week and I looked at it per month and then looked and see, okay, I would have made my payment this month. I would have made my payment that month. I wouldn't have made it. Then I go back and look at the quarter and be like, I might not have made it on this month, but the 2 other months I made more than I needed. So now over the quarter, I still covered it. And when I looked at that tally mark, because I literally had a tally mark in the office, and I put it next to the computer, and I would literally tally it every single time I would have done that test. And after a week, I ordered the machines because I was like, crap, look how many times I lost something. And sometimes when you want to refer it out, what I hate is when I have to refer out something and then it ends up being nothing. And I could have seen it for myself and not have to have the patient go to another provider for really, really long visits, and they're mad at me for co-pays and blah, blah, blah.
Right.
So having the equipment is so much. But I definitely look at this stuff as more follow-ups. That's all it really is, but short follow-ups. 15-minute time slots is what I give to a lot of these follow-ups, because not all of them are dilating. And a lot of times it's the staff doing this. So I'm just seeing them after it's done.
And the last thing that I just really want to make sure that we kind of cover, and we've already hit on it with some of our stories, but the loyalty that you build with these patients is unlike anything that you'll ever get out of just glasses and contacts. They may love their progressives, they may love their contacts, but the truth is they can probably find those somewhere else. But the connection that you make with those patients, whether it's a glaucoma patient who was told, I have one who was basically told that he could not, be treated. He was a lost cause, and he was 20/40 and 20/70 when he came to me 7 years ago. And he's still 20/40 and 20/70 today, because I don't believe that you can't be helped. We've aggressively treated his glaucoma since then. And he is the most loyal person you've ever met. Same thing with some of those tumor patients that you met. I'm sure they don't forget your name because you caught those, you took the time to educate and catch those. So all of those things are going to build your practice revenue and just absolutely help with across the board.
I love it. And can we just say how wonderful this Claris picture is? I'm just saying that I love this picture. I love that camera. It actually gives an awe when I look in there and I'm like, it's so clear and you can see so far out. I caught, some peripheral retinopathy on some diabetics that before my other fundus camera, I was just looking in the center. And I would still dilate and I would look out. When you're going up, down, left, right, even with your BIO, there's some segments of the retina that you're not seeing. We're picking and choosing as we're going along, and being able to zoom in and see that one little bleed. And you know what? That one little bleed means another follow-up. I would have been able to let you go a year, but now you can't go a year because you have this one little bleed here. And it wasn't there before. I didn't see it before.
So
it was
many
not
times
available.
in our office.
And it's so much. And I'm surprised on how much peripheral retinopathy that I am seeing on my diabetics that are quote unquote controlled, or my high blood pressure patients that are quote unquote controlled. And they said they're doing fine. And then I look at it and I say, well, your retina isn't telling me that. So the retina is not telling me that same story. So I'm going to relay that information to your primary or your endocrinologist, and they may have to adjust your medication, because if your eye is still bleeding, then other parts of your body may still be bleeding.
I completely agree with you. That picture, I do want to throw in, that's an actual picture we took in clinic. That's not a stock photo from anything. That's something that our technicians took. So it's very doable in clinic. Absolutely.
Yeah, I hired another staffer, and within a week she was taking images like that. Mm-hmm. So it is easy to take, which I love. The patient sees it, and the next time they come back, they're like, Doc, can we look at that picture you did? I want to see if it's any worse. They want to see, not me. They're like, can you zoom in a little bit more? I zoom in. She's like, no, it looks about the same. And I'm like, you're right. I might call you Dr. Smith today because you've seen it. You're right. It did not get any worse, which is great. Let's keep up doing the vitamin supplementation. Let's keep up doing this. And I'm just going to push you out to every 6 months because you're still doing so good. And then all of a sudden they're like, okay, that's great. Thank you. And they're back at 6 months wanting to see the picture more than me. Oh, let's just go for it.
Yeah, I completely agree with all that, 100%. So just real quick to kind of wrap up, I do want to touch on a little bit of what's going on now. Obviously everything has changed a lot this year. This has been the craziest year I know I've ever seen, and it sounds like probably all of us have ever seen. how has this changed the way that you have approached these medical patients? For us, obviously our protocols have changed. Our patients are waiting in the car. We're masking. Everyone's masking. You're not allowed in the office if you're not. We glove up depending on what we're doing. We're, sometimes shields if needed. I see you're rocking yours in your picture, and we're also streamlining testing. So if they're in for a certain thing and maybe before we might have run a couple of different things, but we can spread that out, then we do that. Or maybe we don't have to dilate every single patient that we would have dilated, but I'm going to get a picture. I'm going to capture something that I can still, we fight the haze just like they fight the haze in their glasses. So when I'm doing, a fundus exam and I'm getting fog on every single view and I'm trying to fight through that, having my clearest picture makes all the world, because I can still confidently say to them, you're great. Everything looks awesome. Of course, we have shields on our equipment and things like that. How have y'all changed? Have you really adapted much, or is it about running the same?
I don't think if anybody says they're the same, they're in trouble. It's not the same. It's not business as usual. But it's also not a problem in which I'm like, oh, I want to go back to the way it was. Because I feel like focusing and zoning in on the patient that's in my chair and not like onto the next one mindset is actually so much better. If you ask, most doctors are actually doing quite well right now as far as the way their practice is running, maybe on less patients per hour, because they're zoning in on what does this patient actually need. So we are cleaning off all the equipment, cleaning everything, washing your hands more frequently, wearing the gloves, masks, the shields. A lot of times when I'm getting really close, I do have the shields on my slit lamp and on my phoropter to keep that separation. And then we're doing a lot of the tests, and that way we can get in and out pretty quickly. But I think zoning in on that patient is so important. Now the patient is comfortable with saying that we're here for this and this is your time slot. So when your time slot is up, we're moving on to the next one, and we're going to bring you back for your allotted time and your allotted test. And they appreciate and they're comfortable with, we're not trying to have a whole lot of people in the office at a time. So there's a couple of things I want to dig a little deeper into, but we can't do that today. So what I'm going to do is I'm going to bring you back, and we're going to do some additional testing, and we're going to separate out that visit. That way they're in and out. And the patients appreciate it because they wait in the car. We text them when it's time to come in. A lot of times there's one person in the optical and one person in the exam room. Then we move the person in the optical out, person in the exam room moves to the optical, and then we move back through, and then we're cleaning it in between. And they appreciate and they like it and they're comfortable with it. The only change for me is I was never a scrubs guy. So I was a dress shirt, slacks, funky shoes. I may even wear a fedora in the office. I was a cool dress. So I had a patient this week and was Dr. Ramsey, you got on scrubs. He said, I ain't never seen you in scrubs. I've been here a long time. She said, I like it, but you was always the too cool for school guy. I kind of like the scrubs though. I was never the scrubs guy, but it's so comfortable and it's so easy. And I think it puts me more in the medical mind. And I realized that my optical has not suffered, but I think having properly trained staff and opticians in the office to do their job, and I'm still doing my job, and even the stuff in the optical, I am prescribing things for them in the optical. I know this presentation isn't about that, but I'm prescribing things for them in the optical. So I have not gotten out of that medical mindset, even with the optical. And then now I zone in more on the medical and the medicine, because I don't have as many patients coming in just to get an exam when there's no problem. Almost everybody is coming in, either I can't see, my glasses broke, or there is a problem. So now all of a sudden, the problem-focused medical mindset is almost every patient. The ones that are plain old with no problems and I'm just here to use my vision insurance, those patients have not been in my office in the last 3 months. So everybody that's coming in has an issue, and we're working on it. So it has made it easier to zone in on the medical model.
Yeah, totally agree with all of that. And, I really hope that through our conversation tonight that those watching are able to take a pearl or two somewhere in there, or maybe get past some of their apprehension about, just diving into this and making it part of their practice, and just changing their mindset a little bit to really incorporate those follow-ups and full care to everyone and each of their patients. And if we're able to help, I know both of us would be more than happy to discuss anything and give some pointers. If you have any questions or anything, feel free to contact us. But we really hope that y'all were able to take some little pearls and run with them tonight.
Thank you. Thanks for having us. Enjoy.